Hello, this is Ward Stevens, and welcome to Lecture 17. The topic of this lecture is the patient-centered medical home. There are 7 learning objectives for you to take a look at, and please do so at your convenience. So I just want to first start talking about some of the challenges that are faced by the healthcare system here in the United States. These were identified by the Institute of Medicine back in 2013, and while that may seem like a long time ago, I believe that these challenges are all true today. The first is that the treatment options that are available to healthcare providers to offer to their patients just continues to grow at really an amazing rate, whether it's new pharmaceuticals or new imaging or new procedures. I can remember a long time ago, and I think I shared with you, and this is even before I would remember, but in my lifetime, the state-of-the-art treatment for a heart attack was bed rest, and today there's all kinds of interventions that the healthcare system can offer that really improve the chances of survival significantly and offer patients the opportunity to live a pretty healthy life despite their condition. Another big challenge is simply the increase in the number of chronic diseases and the complications that are associated with those diseases. Some of that is because of lifestyles. Other parts of it have to deal with just simply the fact that because our health system works or has some impact, and people having access to food and clean water and things that were not always available, people live longer, and as they get older, they're more likely to pick up a chronic disease. And while there has been a lot of consolidation within the healthcare system, care is still often fragmented, particularly for the elderly who may be seeing multiple physicians who are not communicating with each other. Patients bouncing between health systems for whatever reason, and information not going back and forth. And then there are variations in quality among different populations. One example is just where you live really matters. If you live in a rural area or in a medically underserved area inside a large metropolitan area, and those do definitely exist, the quality of care that is and the value of that care is just differs. If you grow up in a poor area where they're not healthcare providers, your quality is just going to be different, and that's unfortunate. And then, as we've talked about before, the cost of the healthcare system in the United States just continues to increase pretty significantly. Some other challenges that are faced by the system is often that the clinical research that is done doesn't always address the pressing clinical questions. A lot of research is done at your large university settings that see very sick patients, and they're not always answering the questions that physicians in a primary care office in a community really need to have answered. And while I think there have been some improvements in that over time, but the clinical research isn't always giving providers what they need to know. And kind of jumping off of that is, even if they do have information that would be beneficial, it's often very difficult to get that information to clinicians and patients, so they might consider different options for care. I think many years ago they developed beta blockers, I believe, for heart disease, and according to the Institute of Medicine, it took approximately 13 years for the use of those drugs to be used in healthcare. And I can't remember whether they're actually still using them or not, but it was at that point in time seen to be it was believed to be the state of the art treatment, and took a long time for the healthcare profession to adopt those recommendations. And then we've also before talked about fee-for-service medicine, and the fact that it encourages perhaps excessive care because you get paid every time you do something. You can discourage collaboration between providers because everybody gets paid for what they do, and can increase the risk of patients because the more that is done to someone, the more procedures, there's an increased chance for harm to the patient. But a really big conclusion was that the complexity of our healthcare system is basically reaching the point where an individual human does not have the capacity to know everything that they need to know. And again, it just the number of treatments that are out there, the number of diagnostic tools that are out there, the number of diseases that are out there. It's just really, really, really hard for just one person to know that. It's really, really hard for several people to know about that. And, frankly, is one of the reasons why there's specialization in medicine. And over the years, that things seem to be getting narrower and narrower. 40 years ago, you had general surgeons and vascular surgeons and colorectal surgeons, but just about all those surgeons did general surgery and did these other things as kind of just something additional that they did. Today, surgeons, if they do vascular surgery, they pretty much do vascular surgery and so on. So there's also that need to, as I mentioned before, just the growth in chronic illnesses. We need to address those. And which ones are the big ones? In 2021, the top leading causes of death included heart disease, cancers, COVID, injuries. Then you can see the rest of the list there. But a lot of those are chronic. One of the things that I kind of found interesting, just going back a few years, 2016, is that some of the two items are no longer in the top 10. One was suicides, and the other was influenza and pneumonia, which probably got potentially gobbled up in the COVID-19 numbers, but that's really kind of hard to tell. That's just conjecture on my part. But when we look at chronic diseases, and it's certainly important to address them, we also need to recognize that it should be no surprise that these are the top, I'll just call them the top killers. If we live long enough, one of these things will probably be responsible for our demise, and that shouldn't be a surprise. But having said that, when you look at some of the numbers for heart disease and cancers and some of these other ailments, many of them also strike people who are, not that old, less than, well, as I get older, young seems older, but, a lot of people in, kind of midlife can also suffer from these diseases with devastating outcomes. So it's important we do address them. But how do you manage all these older people who are suffering from sometimes not only one chronic disease but multiple chronic diseases? And the impact of chronic diseases is pretty big. In the top chronic diseases, 55% of all deaths in 2021. 65% of those deaths in 2016. Not sure what that change was. They do account for about 80% of healthcare spending and contribute to mortality, disability, and so on. And it's their impact is when you consider is large, particularly when you consider that over 50% of the population has at least one chronic condition. Now, chronic conditions, what is their root cause? A lot of it has to do with behaviors, things like tobacco use, alcohol use, poor nutrition, or lack of physical activity. All of those can contribute to chronic diseases. And at some level, and for some parts of the population, it could be pretty much strictly behavioral. However, we must not forget that there are other determinants out there that can impact this as well. If you grow up in an environment where it's not safe to go outside, that lack of physical activity could catch up with you over time. If you live in a food desert where there's no grocery stores offering healthy food options, that could impact your chronic diseases as well. If you grow up in a household where others around you have a history of alcoholism, there's a high chance that an individual, born into that, the same thing with tobacco use, could, follow those same patterns. So, in a sense, it is behavioral. However, there are a lot of things that can drive those behaviors. Now, some of the challenges in reducing chronic diseases is that it usually takes a long time to develop. I mean, if you are, for example, this may be a bad example, but if you are a smoker, it might take you 30 years to develop emphysema or some other lung disease. And for many of these diseases, there's often no cure, just expensive procedures. There's still cancers out there that are extremely difficult to treat. Cancer certainly not as bad as it was 40, 50 years ago, when if somebody had cancer, you pretty much knew that they would pass away. And a lot of progress has been made in that area, but it's expensive. And the other thing to recognize is that there's no money or no profit in preventing diseases, kind of perhaps driven by our fee-for-service model. If we go out there and say for example, we limited or reduced heart disease by 50%, there might be a lot of hungry cardiologists out there. So and companies that make products to take care of heart disease. So our system is kind of set up where you're only profitable if you produce profits, and keeping people well isn't financially rewarding. Though I would think that from a service standpoint and a humanity standpoint, it should make you feel well. However, it doesn't always. That's not necessarily going to pay the bill in the way that our model is currently set up. And there's also kind of little evidence out there to support that health education actually improves health. I believe I've said that before. I mean, within the healthcare system, we certainly put a lot of emphasis on education and tobacco cessation and diabetes management and that thing. But at least as this study back in 2017, the authors found that there just didn't really improve things that much. So when it comes to addressing chronic conditions, there are a number of things that are important. One is engaging the patient in their health. Part of that's educational, right? And I just said that didn't work. However, that is one thing or one route that can be pursued. And then it also helps to involve not only the patient, but also their family in involving them in the decisions that are made. Family can be a very positive influence. Family can also be a negative influence. However, if the patient and the family are involved, then it's perhaps the outcomes will be greater. And then finally, just the whole area of prevention. And there are those that argue that it's doing the prevention it is very expensive. If you have all men over the age of 50 every 10 years getting colonoscopies, that's expensive. And if you were just looking purely at the finances of it, you probably wouldn't do it, because it would be cheaper just to prevent or to take care of those cancers when they showed up than to do all the prevention. However, that's not a very patient-centered approach, now is it? But so let's move on to, as I mentioned, patient-centered to patient-centeredness. Now, this is a definition from the Robert Graham Center. They're a great source of information on many topics. but they state that patient-centeredness refers to healthcare that establishes a partnership among practitioners, patients, and their families, when appropriate, because some patients don't want their families involved, to ensure that decisions respect patients' wants, needs, and preferences, and that patients have the education and support they require to make decisions and participate in their own care. And this may not sound like a wild idea to you. However, if we look historically at the way medicine was delivered and maybe still be delivered this way in many settings, often it was the physician who basically decided what would be done, and they would make a recommendation, and patients would typically follow those recommendations. And the physician has a lot of good information, and patients don't. But not engaging with the patient, involving them, doesn't help with outcomes. So to kind of summarize that, I don't necessarily recommend that you try to memorize this definition, but if you remember the following, that patient-centeredness requires a partnership between the care team and the patient and their family. That patient-centeredness respects the patient wishes, and it also helps to, part of being patient-centered is educating and supporting the family and the patient to help, them make the best decisions for them. And just kind of a little, side note is as you go into your career, it's very likely that you will run into patients whose wishes are contrary to what you feel their wishes should be. A good example of that is that a Jehovah's Witness, based on their beliefs, that it is inappropriate to receive blood and blood products. And they may show up in the emergency room and say, I don't want that. And you could be the physician there and the surgeon there or whoever, and say, if I don't give you blood, you're going to die. And the patient may well say, yes, that's what I wish to do because I do not wish to have blood. And so sometimes those things are hard. They're hard to understand why someone would do that. However, when it comes to kind of tying back to medical ethics and the whole issue of autonomy, it's very important to respect the patient's wishes. Though I will note that a Jehovah Witness parent cannot make that decision for a child. As one judge put it, the Jehovah Witness parent cannot make a martyr out of their child. So they're grown adults who are capable of making a decision. You need to respect their wishes. If an adult is making a decision for a child, there's some things you have to recognize and deal with, but that's another course. All right, so patient-centered medical home, the PCMH. Back in 2007, the Robert Graham Center stated the following, that PCMH is likely to be the best opportunity for aligning physician and patient frustration, demonstrated models for improving care, and private and public payment systems to produce the most profound transformation of the healthcare system in anyone's memory. Now, the concept of a patient-centered medical home is not something that is really that new. The idea was introduced by the American Academy of Pediatrics back in 1967. A few years later, they adopted that as an official policy of the American Academy of Pediatrics. And then the World Health Organization went on a few years after that to kind of define what the basic tenets or principles of a medical home include. And then the pediatricians also defined 37 specific activities that a patient-centered medical home should focus on. Now, today, about 20% of primary care physicians practice in patient-centered medical homes. There are about 100 payers who support it, that being insurance companies, and they do provide additional payments to what are known as base rates. So let's say for a physician visit going to a non-PCMH, they might insurance company will just say we'll pay $50. If they are at a PCMH, that payer might pay $105 or $110. However, they do base those payments based on performance metrics and also the number of at-risk patients that are located being seen by the organization. And then, PCMHs also have the opportunity to be accredited by an entity called the National Center for Quality Assurance, or the NCQA. And there's some other certifications that they can apply for as well. So, mentioned previously that there were some tenets that came up with regards to the patient-centered medical home, and there are, I think, 7 of them. 3, 4, yes, 7 of them. Yes, I counted it twice and got it correct. I hope I don't get that wrong. But those components include a personal physician who directs the personal physician and the physician who directs the medical practice could be 2 different individuals. It has a whole person orientation. They are responsible for coordinating and integrating care, having a focus on quality and safety, improving access, and it's also related to payment reform. So let's talk about each of those for just a few minutes each. So the first one, the personal physician. I think if you've been a patient before, or you've had family members who are patients, the physician-patient relationship can be a very valuable thing, particularly if you live in one area for a long time. It's nice to have a physician who knows you, if you have a track record. And so when you show up, it's not new all the time. For example, if you just go to what I'll just call a doc in the box, or an emergency room where there's no relationship at all. I do believe that today's modern kind of our society makes it harder to develop that relationship because populations are much more mobile. Neither one of my children live in my hometown. I don't live in my parents' hometown. And then, physicians, they're often, they have make decisions to move about as well. So I think as a whole, our society's a little less attached to location than perhaps we were in the past. So it makes it a little bit harder to have that. And then, fee-for-service medicine has been accused of creating barriers to developing relationships as well. Perhaps the patient not trusting the provider to do only what they need to do. But it has been shown that continuous care with one physician can lower cost and improve outcomes. So a big component of it. And then the second one related to physicians is that the practice is directed by a physician. And who are they directing? They direct the care provided by a multidisciplinary team. So, it's not only that, they're going to come in and there may be a nurse practitioner or a physician assistant who provides some care. There may be social workers or dentists or other professionals within a patient-centered medical home. However, it's the physician who has a relationship with the patient who will, kind of decide overall what's going on, approving care plans, and making sure that things do not fall through the cracks. And, with a lot of complicated patients out there with a lot of chronic conditions, things can fall through the cracks. So the physician needs to make sure that there are processes in place so those things do not occur. Now the third area is just a whole person orientation. Hopefully, again, I think this is hard, but to care for all stages of life. When I worked in Allegheny County, Virginia, there were physicians who'd been there a long time, families who'd been there a long time, and I had one physician who I think was taking care of the grandparents, the parents, and their children. So he was coming toward the end of his career, and so he had a real good relationship with that family. But in a patient-centered medical home, the entity should be able to care for all or provide all the services that anyone would need from the time they come into this world until the time that they leave it. And then not only deals with the body, but also deals with, and according to the document in the Robert Graham Center, to deal with the spirit and the mind, and also to be culturally appropriate. And I think a lot of times when you look at FQHCs, one of their advantage, or not FQHCs, their type of patient-centered medical home, and we'll get to those in a few moments. But these organizations often place themselves, within different areas, or where, for example, there are a lot of African Americans or a lot of Hispanic, people living. They'll have, their organization there. Hopefully, be able to hire staff from the same culture, and so on. So they can provide and meet the needs that of that population that might be different than other populations. And then care is coordinated and or integrated. So in a patient-centered medical home, the entity and the physician is just not responsible for what happens within the walls of that organization. If they have to be referred out to other providers, because they're going to have to, because the PCMH can't provide every single service itself. Probably not going to provide a whole lot more than primary care, diagnostic test, radiology test, perhaps dental care, social services, and so on. But if they leave the organization, the physician or the entity continues to be involved with that. And they also focus on making sure that healthcare information is transferred between providers as quickly as possible. And this is important because if you've ever dealt with patients, or it's pretty much any group of people, that people are not always at best at communicating information. If you don't believe that, ask my wife. If you don't believe that, listen to too many of my lectures. So, so communications are imperfect, and it helps, particularly with patient care, to involve, have that entity make sure that the information is efficiently shared. PCMHs also have to focus on quality and safety. They will use things such as evidence-based medicine, performance measurement tools. They may be voluntarily recognized by accreditation agencies such as I mentioned before, the NCQA. But something that they are required to do is involve patients in quality improvement efforts. And think how valuable that could be for to receive hey, what does the patient think about all this? Because patients, many of them have really good insights and can provide good information on how to improve processes and improve the outcome or the value of the care that is provided. And then they also use electronic health records. And then I think this is number 7, is that PCMHs also have expanded hours into evenings, weekends. They will often provide patients access to the electronic medical record, and also offer online scheduling. Again, these are things, they're not only done at patient-centered medical homes. Your normal primary care, I would say, I don't know what normal is, but your standard primary care offices, often many of these will do the same thing. But for PCMH, they're pretty much required, especially if you're going to meet accreditation requirements. So what do PCMHs look like? Who's operating them? Well, there are private practices and those that are government funded. And not going to really talk too much about the private practices, because I think the biggest bulk of them are clinics that are funded by the Health Resources and Services Administration. The organization it can apply for a grant to HRSA. The result of the grant is they can receive basically kind of startup funds to buy equipment. Then they also are able to receive the enhanced reimbursement rates for them to be able to provide all the services that they're responsible for providing and coordinating. And I think these numbers are from about 2017. But in 2017, about the PCMHs were providing care to about 1 in 11 individuals in the United States, 1 in 8 children, 1 in 5 rural residents, and 1 in 4 of the uninsured. So you can see that they are a very important part of our healthcare system. Now, I think I mentioned federally qualified health clinics a few moments ago. That they are funded by HRSA, receive startup funding, but some of their key characteristics are that they are community based and located in a medically underserved area. But medically underserved, I often think of it as being rural. However, there are FQHCs that are located in big cities where I think there are federally qualified health clinics in Boston, Massachusetts, which has more physicians per 100,000 people than I think anywhere else in the United States. And that's just a guess. I can't say that, but I know the state has more physicians per 100,000 people than any other state in any of our states. But there are, even within the Boston metropolitan areas, that are medically underserved. Kind of mentioned before that they provide comprehensive care. Not always, again, they're not going to provide every level of service, not doing inpatient care, but they're doing what they can with the resources that they have, particularly at the primary care level. And then they also have to coordinate care with those other entities. They also receive enhanced reimbursement from Medicare and Medicaid. I kind of mentioned that before. They have some very stringent performance requirements that can impact their pay, typically related to patients hitting certain numbers, such as the percent of patients who have the appropriate, what's it called, the A1C levels for their, with their diabetes. They also offer, sliding fee scales for individuals up to 200% of the federal poverty level. So if somebody was at 0% of the federal poverty level, then they could probably just come in and not have to pay anything, but they will pay something, less than kind of the full rate up to about 200% of the FPL, and then after that, they may have to, pay the bill. FQHCs often, they take Medicare and Medicaid, but they also will accept insurance from your private payers. And then their governing board must include patients. And patients have to be a significant part of that governing board, just basically under that if you're going to have a community-based program, bullet point number 1, then maybe it's a good idea to have people in that community making decisions on behalf of that community. And then FQHCs are also eligible for teaching health center funding. We will probably talk more about that on a presentation about graduate medical education that I may work into this course here in a few weeks. But right now, all residency program funding from the Medicare program goes directly to hospitals. The hospitals are the only entity that can receive that and be paid for, doing a family medicine program, internal medicine program, or any other program. But it was recognized that a lot of care is now provided on an outpatient basis. The residency funding model is based on an inpatient model largely. And so HRSA will provide some funding to cover the cost of the residents as well as cost of the administration of the program. And then there's also the National Health Service Corps. Federally qualified health clinics can provide loan repayment to individuals. Basically you go there and work a year and they'll pay, and I'm making this number up, the number changes. I think I've seen it as high as $50,000 or $35,000 for each year of service at the FQHC. So these things are out there. They take care of a lot of people, but do they work? Well, kind of some of the what areas that studies have looked at have been, the access, the health disparities, cost and utilization, quality, and satisfaction. And there was a 5-year cohort study back in about 20, done I guess in 2015. It was printed out or published back in 2016. Is that PCMH showed some modest improvements in some areas compared to a control group of medical practices. They outperformed the control group on 2 measures, and that there was no difference on 4 measures. So, are they doing better? Kind of hard to really say. In some areas, yes. Some areas, no, and are doing better, and some pretty much doing the same. But I think that given the fact that they are primarily located in medically underserved areas, that the quality of care that those populations are receiving is probably pretty good. On utilization, they did find that there were some changes in utilization rates. PCMHs definitely had more primary care visits and fewer specialty visits, which I believe is a positive. And I think because the doctor is involved in coordinating all care, knowing what's going on, fewer diagnostic tests are ordered as well. So on the utilization side, probably doing better. And then in the area of access, I think that there's really 2 ways to look at it. One, this is just from the National NCQA, is what they found is that patients in the federally qualified health clinics had higher rates of cancer screening. But I also believe that with the establishment of these clinics and the requirement that they are located in a health professional shortage area or medically underserved area, that there are clinics probably located that are supported through this program that probably would not be there without it. So the additional funding for Medicare and Medicaid that I mentioned before, the startup funding that they can receive to get it really helps maintain the financial viability of the FQHCs in communities that don't have the resources. And FQHCs have also had impact in some areas regarding disparities. Increased cancer screenings was one example. It did, this study found, or the NCQA reported that they reduced the disparity in breast cancer screening by about 50%. So some progress there. In the area of cost, while the other areas seem to me a little bit, maybe so, maybe not. The NCQA reports that the PCMHs have been successful in lowering spending per Medicaid beneficiary because they can use CCare PCMHs. They resulted in 62% lower hospital spending for their members and reduced the use of advanced imaging. And in addition, I think because with increased availability, longer hours, open on weekends, in the evenings and so on, that they were able to slow the growth in emergency department visits, which can have a huge impact on cost. And then in the area of quality, they were able to increase screenings for things such as depression, increase in adherence to diabetes protocols, and also improved, and I believe this is related to diabetic patients, improved the percentage of patients who had their eye examinations. And then in satisfaction arena, about 73% of Medicare beneficiaries indicated they wanted PCMH style care. So when you look at all of these things, think for a moment, okay, remember that value equation, right? Value is a function over quality and cost. And with quality being related to patient satisfaction with outcomes and safety. And it seems to me that while this is a little bit soft, I don't have a whole lot of hard numbers on it, is that the PCMH does and FQHCs do provide value to the patients that they serve. We could probably argue that they could provide more value, but they're doing a pretty reasonable job. And my personal opinion on it is that if they are so good, then why do you have to apply to HRSA to get a grant to be able to do it? If they're really good, why don't we just pay people the enhanced rates so that more practices have the resources to provide better care to the patients who come to the practice? So that's Patient-Centered Medical Home. Thanks for listening. Please contact me if you have any questions.